So we're going to give a bit of an update on a study that was really started a bit over a year ago, which is looking at PSMA scans and this was run through the 3 DHBs up here in Auckland. We're kind of lucky here in Auckland that we have 3 district health boards that all work together from a urology end, and so we're able to run this study. We've got a few conflicts that I should just let you know, just so that you can know whether to believe what I'm saying or not. So I'm a urologist at ADHB. I also work in private in Auckland here, do some examining stuff, but I'm also just on the Ministry of Health advisory sort of committees of prostate cancer workforce there. And probably important to note is I don't have any financial relationship to all of these PSMA studies. So although I do work with the guys at Mercy Radiology who do these scans in private in Auckland, I have no financial motivation here at all. So just as a quick outline, this probably won't take too long for us to go through, but I really just want to go through, the thinking about this study. So we really wanted to identify a problem in the first place, and our answer for this problem we felt was a PSMA scan. The difficulty is that how do we actually prove that this scan is worthwhile doing, and also how do we get it funded in the future? So the problem we've got is that when someone is diagnosed with prostate cancer, we want to really evaluate what's going on at the time. You really want to know what type of cancer they have. You want to know what stage it's at. Is it early? Is it in the middle? Is it late? And you also want to know how patients will tolerate treatment. That's why it's so important to talk to the patients and work out what the best treatment option is. But you can't actually work out a treatment option until you actually know how bad the cancer is. One treatment protocol for one patient may be a disaster of a protocol for another patient. There are several decision points that we look at. The first one is, does it need to be treated? And this is something that everyone needs to be aware of, that is a lot of low-risk prostate cancer doesn't need to be treated. If we rewind 20 years ago, everyone with prostate cancer was treated. Now we have a lot of people being observed with low-risk prostate cancer. Then the question next is, well, if we've decided this needs treatment, should we be doing surgery or radiotherapy? And these are really, once we're getting into the slightly nastier cancers here. Then we start making the next step up where we're saying, does it need surgery and radiotherapy? Should we be giving hormone treatment and radiotherapy? And these are all the decision-making points that we get more and more worried about now. The new thing that's come on the horizon is should we be not doing surgery or radiotherapy, and should we be looking at chemotherapy in the patients? If we just rewind things 5 years ago, chemotherapy was the last-ditch effort in prostate cancer. Now it's being used early on because it's been shown to have a survival advantage. And this is why it's becoming increasingly important that we know what's going on early on so that you can make a good treatment plan early on. So the question is, how do we really decide how bad it is, how much it's spread? Well, traditionally, radiologists just tell us. We send patients off for a couple of scans. We send them off for an MRI scan, often a bone scan, which this is an example of a bone scan here. And you can see these black areas here are dots of prostate cancer that show up, and also in the pelvis here. And it looks pretty obvious on this patient's got spread of their prostate cancer. This person's PSA might be 200. When you've got a patient who's got a PSA of 10 and you want to see whether it's spread, these things are a pretty gross tool for looking at signs of spread. Likewise, a CT scan, you can scan a patient's entire body, but if you're looking for 2 or 3 millimeters of cancer, it's literally like looking for a needle in a haystack. MRI scans are good. You can have a look at the prostate gland, but they don't really look for spread. And so we're lacking for something that's really good at finding spread of prostate cancer. We did start using some we call sodium fluoride PET scans, but they've sort of gone a little bit out the window. And the latest thing on the horizon is what we call these PSMA PET scans. So the question is what is a PSMA scan? And this is really modern medicine, and this is the way that things are going. So it essentially is a glorified CAT scan. So PSMA stands for prostate-specific membrane antigen, and as the name implies, it's specific for prostate, but as most things in medicine happen, there's always an exception, and it also will stain a couple of other things, but we know what those things are. But so you've got this protein on the outside of a bit of prostate, and a bit of prostate cancer cells in particular. So if you have a bit of prostate that's in your lung, you know that shouldn't be there. Prostates don't live in lung, and so it's likely to be prostate cancer. So if you target this protein, you can actually see cancer throughout the body by doing this scan. So basically, we get a label made, which is a little dye that binds to this PSMA, and it's actually made in Sydney, from what I understand, and then it's flown straight across to Auckland. It's transferred from the airport to Mercy Radiology here, and I'll mention that it is available now in other centres, and it's injected into the patient. As I said, it binds to anything to do with the prostate or prostate cancer, but it will also bind to salivary glands, and we know that, and we know that somebody hasn't got spread of the prostate cancer to the salivary gland. It's just one of the places that it binds. And then you do a CT scan of the entire body. The PET scan is just like this. This is a pretty classical looking one. It's just a donut that you lie through, the same as you would for any other CT scan. Some people may get a little bit claustrophobic, but it's generally not as upsetting as an MRI scanner. But the important thing is you get these great pictures here. So if you look on the right here, this is just a straight out CT scan. And you can see here that you can't really see that much about what's going on. To a urologist or radiologist, you know that this bit's abnormal because that shouldn't be there. But when you look at it on a scan like this, it's really obvious so that you've got that lights up like a Christmas tree. And that's a bit of metastatic prostate cancer, and there's no way that you can miss that. On a case like this, it doesn't make too much of a difference because you should have picked up that lump anyway because it's a reasonable size. But if you're looking at other patients, like this one here, you can see these tiny little areas here. It's 1 or 2 millimeters in size. It's up in the chest. And you can look at some further ones here. And these are all lymph nodes, all these tiny little lumps here. Now, if you were to do a plain CT scan, you'd just ignore those as being normal lymph nodes. But in the setting of a scan here, you can actually show that this patient has metastatic prostate cancer, not just to one site, but probably dozens of sites. And these are not the sort of situations where you want to be embarking on major surgery because you're just not going to cure the patient. Likewise, when you look for a bit of an abnormality within the bone, you can see here it's lighting up like a Christmas tree. Now that would be often hidden amongst the bone because it's difficult to see cancer in that area. And so it's really much better at us actually seeing metastatic cancer. So the advantages from our end is that this is a full body scan. So you're looking at every single part of the body. It's a one-stop shop. So before, when we do a CT scan and a bone scan, we're now just doing one scan. And so we have the ability to look at all of those different areas in one scan. It's sensitive. That means that if there is some prostate cancer there, it's the most likely scan that we have for finding it. And it is specific, which also means that if it does light up, it means it's highly likely to be prostate cancer that you're seeing. There are a few caveats for that, but that's where experience comes in. And so we can get a much more accurate picture of how bad this disease is. The disadvantages, number one's the cost. So getting people to actually fund this is the biggest hurdle that we come across. The other thing is that it's new, and so you're always wary when something's new about whether it's as good as people say it is. And the last thing you want to do is actually decline people treatment based on a falsely saying that they've got metastatic disease. We haven't really know whether it underestimates the disease or overestimates it, and I think as time's gone on, we think that it still underestimates the disease. But the other thing is that our previous data always looked at CTs and bone scans, and so we say that we're doing someone a favour because we've operated on their prostate cancer when their CT and bone scan is negative. Maybe if their PSMA scan is positive, they are still getting an advantage by debulking the disease. It's difficult to know, but that's sort of data that will come out with time. As I said, if we overestimate the disease on the scan, we can do some harm. The difficulty is how do we work out how good it is, and how do we work out whether it's worth the extra cost? Now if I go across to the DHB and I say, can you please fund this scan, which costs about $2,500, they're going to say, show us the evidence. And then if I see a patient in private who's had a PSMA scan, and then you ask the insurance company, we also do a CT scan and a bone scan? They'll be like, well, why? We've already done the PSMA scan. We're not paying for that. So really the only route for this is to actually get external funding, to actually get some data to prove to say that we should be doing these scans in patients in the public system. And that's where the Prostate Cancer Foundations come in with this, is they've stepped in and funded this study to get these scans done. It sort of has two effects. First of all, it's an advantage to those patients that are having the scans done because it helps with their care. But probably more importantly, this gives us the opportunity to actually show how good this scan is and how it can actually be a cost-effective thing when introduced in the public system. So our plan was to get 60 patients who've had a CT scan, an MRI scan, and a bone scan, who are then going to be undergoing high surgery for prostate cancer. These were specifically high-risk patients, and the reason for that is that money's valuable, and you want to get the biggest bang for your buck. And if patients are more likely to have metastatic disease, you're more likely to be able to show a change in the results. So all of the patients had all of the above scans. Now they were all funded through the Prostate Cancer Foundation, and all these scans were done prior to the patients having surgery. Now, in some studies, you would say that you are polluting it by giving people the results prior to doing the surgery, where we felt that is unethical, so all the surgeons and the patients were told of the results of their scan prior to having surgery so that they could change their mind about treatment. And as I said, that all of the scans were reported independently. So the person who was reporting the bone scan was different to the person reporting the PSMA scans, and they didn't communicate between each other. So our accrual was a bit slower than expected, and part of this was because the requirement the patient needed to have surgery. It wasn't because we were surgeons and wanted to take all the patients for ourselves. It was more the fact that we wanted to validate the data to say that if we cut out a lymph node that we knew that it did have prostate cancer in it. So we're checking to see how reliable the scan was when it said there was cancer. This data's increased. It's now up to just under 40, but a couple of patients were removed from the study because they decided to not go forward with surgery, so we had to take them out of the analysis. One patient we found to have colon cancer when we were working them up, and another 5 were awaiting surgery. There was no complications from the scan. This is really where the study's results come down to. We had 4 patients that had lymph nodes that were positive on the scan that were not positive on any other form of imaging. So those patients went forward and had surgery plus removal of those lymph nodes. More importantly, 5 patients had metastatic cancer that was missed on the other scans. So these patients didn't end up having surgery because they had spread of their cancer well outside the area where we could do the operation. And so they avoided the morbidity of going through an operation, and it avoided the cost of going through an operation for the public health service. Interesting note, one patient there also had a bone lesion that was suspected to be metastatic disease, which was found to not be it on the PSMA scan. So if we look at the numbers needed to change treatment, to have any change in treatment, you need to do 3 of these scans to change the patient's treatment. Now that's probably not such an important bit of data, because the reality is as soon as you mention that, you start opening, or did the change in treatment change the outcome? And that's a whole nother argument altogether. But the more important thing is that you only needed to do 5 of these scans to stop one patient getting a needless operation. And when we say needless, you've got the cost of an operation, which can cost about $15,000 in the public service, but you've got the post-op care, you've got the effect on the patient's life. And that equals about $5,000 in extra cost to the DHB per patient that would have had, that has avoided an operation, and you've saved about $15,000. And as I said, this data we will hopefully finalise in the next few months. We've learned a lot about the scans, and we've actually found them really, really useful. This is an example of how it can be so useful in showing metastatic cancer. So you can see here, this is prostate cancer in there, it's lighting up. That there is the same spot on a CT scan. And if you looked at it very carefully in retrospect, you might be able to say it's not quite right, but no one would ever make that call. Now, this is the same patient 6 months later on hormone treatment. You can see that's all cleared up, and now you can see it. So, you know, I'd much rather know about it back here than down there, because you would never operate on a patient that's got a lesion like this, because you're not going to do them any good. We've found that it really helped us plan the surgery as well. These are all extras that are unmeasurable. We have found that if one lymph node was positive, it was not uncommon that you'd have another lymph node or two that were positive around the area. So we'd never take out one lymph node, we'd take out a group of them. And if the scan was positive, it was almost always that there was prostate cancer in it. The other thing to note is that it did actually help improve our local imaging. So we do an MRI scan to look at what the prostate cancer looks like around the prostate. To tell you the truth, the PSMA scanners started becoming more reliable at actually assessing that than the MRI scanners. So we think our final results will sort of basically result in these scans becoming a routine in the public and the private service. We think they're going to be cost effective. Yeah, I think the data is really pretty clear already, and we're actually looking at stopping accrual early because of this. And we think this will help determine our treatment planning. There's another couple of implications for the future with this, is that this is expanding our knowledge about the use of this marker. You can imagine that, if you've got a little chemical that sits on a prostate cancer cell, that's the perfect thing to target with chemotherapy. If you can bind something to it, you can bind some radiation to it. You can bind some chemotherapy agents, and we know that we can actually target these in the past. This is a bit of an example here. I won't bore you with those details, but that's looking at immune response to a protein that sits on prostate cancer, which is called prostate acid phosphatase, and this was a licensed treatment in the States. LUTETIUM, who I think is becoming available. I can't remember but there's a bit of a push for that. This is a radioactive little isotope that they bind to PSMA, and you inject it into a patient. It binds on the prostate cancer cells in the same way that this dye binds on, and it administers radiation to the prostate cancer cell directly. So rather than aiming the treatment from the outside at 10 different nodes, you're basically putting it into the patient's vein and letting it bind itself to the prostate cancer. And that's been shown to be quite a promising treatment. People are also using this exact same method to deliver chemotherapy. Why give the whole body chemotherapy when you can aim it directly at the prostate cancer cell? So they bind these PSMA targets to so there's the docetaxel that we use for chemotherapy, and that's being trialled as well at the moment. We're also looking at what we call treatment of oligometastatic disease. So if you've taken out the prostate gland and then the PSA comes up and you've got one lymph node that's positive on the scan, do you end up treating that? There's debate. There's people saying both sides. We do seem to think that sometimes it can be the tip of an iceberg. Will it improve survival if you start treating all of these lymph nodes as soon as you can see any cancer? And can you really cure it? These are all things that are up for debate at the moment. But at the moment, what we're able to do is actually minimise morbidity, and minimise the side effects of prostate cancer treatment. In particular, our radiation colleagues are getting a lot better at aiming at, a single lymph node, a single bit of rib, those sorts of things to improve outcomes. I think, a few people just to really thank with this. Remy Lim, I think, talked here last year. I sort of thought I should brush up on his last year's presentation before I came, and I had a bit of a look at that this morning. He's been a bit of the driving force behind these scans in Auckland here. He's been, and it's important to note that all I've been talking about here is these PSMA scans in Auckland, and from what I understand, the last few months, these scans have now become available in Christchurch, Wellington, and maybe Hamilton. So they, I work in public and private, and I'm very much against, uninsured patients paying for things, but this is one of the exceptions that sometimes I talk to patients about getting this done, because it's such a game changer. If you have high-risk prostate cancer and you're about to have surgery, get a scan like this done that shows spread. You've avoided, something that can be, cause trouble. So I have all the urologists from the Auckland region that have been sort of contributing to this, but I think, this is one of the really important sort of things that the Prostate Cancer Foundation's got involved with from our end of things, because us managing to get funding for this, this scan in the public service would be like getting blood from a stone, because nobody wants to run trials like this, because everybody's got an ulterior motive. You have to get the money from somewhere independent. And Mercy Radiology has helped the study to get underway by giving us a discount on these studies, but I think they've really helped.